non-communicable diseases, prevention, when, where, which, and which way, that is very important. Now, all of us know that the life expectancy is increasing, but this increase of 6.6 years is not keeping pace with the healthy life expectancy, and that healthy life expectancy we are not able to achieve because of the non-communicable diseases or the chronic diseases like CVD and other comorbidities, which if they occur at the same time and life expectancy is increased by another 4 years. So what we are increasing is this morbidity here. So this morbidity cannot be decreased until unless either we delay it, near it, bring it as near to our death time as possible, or complete ameliorate these chronic diseases. So what we have to do for that? Perhaps whatever we have been doing, our thought processes have to change somewhere along the line, because the incidence of these diseases has been increasing, and all of us know the burden of these diseases, of CVDs, diabetes, cancers, chronic respiratory diseases, and another non-communicable diseases, which are 60% responsible for disability adjusted years and 70% of all global deaths, and 41 million people die. As Dr. Sharda Jain very, very wisely said to start with in a single sentence, that we really have to be scared of these deaths because of the morbidity and mortality. And common risk factors which are there for non-communicable disease, which we have been thinking so many times, are the ones responsible, or the tobacco use, physical inactivity, unhealthy diet, harmful use of alcohol, so excess salt and everything. But metabolic risk factor, increased blood pressure followed by overweight, obesity, raised blood glucose, which is called the metabolic syndrome, is also very, very important factor. Now, what's happening normally? What is the traditional thinking? Is that the menopause transition increases the risk of metabolic syndrome. Yes, that is true because of the hypoestrogenic state and because of the weight redistribution and the metabolic changes which are occurring more at this time, and more of atherogenic lipids are increased. The metabolic syndrome increases in the menopause as compared to the premenopause. But the problem is that even in the premenopause, in the adult population, the metabolic syndrome incidence is very high. In our own studies, it was 50 to 60%, and even other studies, it has been found to be 30, 40, 50%, even some South Indian studies have shown. Along with that, another factor which is increasing is because of the life expectancy, women in the menopausal age group, they are increasing in the later on midlife women. So those have an added risk because of these metabolic syndrome. So we have a prevalent risk which is already there. Added to that is the menopause there. So what is metabolic syndrome? Is a group of the metabolic disorders which are the central obesity, BMI more than 30, or any of the two of the following criteria. If these are present, obesity and weight, which is for the Asian, more than 80 centimeters. Hypertriglyceridemia, more than 150, reduced HDL, less than 50, high blood pressure, more than 132, diabetes, diastolic, more than 85, or on treatment of previously diagnosed blood pressure and all that. So this is survey done by us, which show the point prevalence of metabolic syndrome to be very, very high. Indian data on epidemiology of metabolic syndrome have again shown that point prevalence is very, very high, and incidence increases more in the urban areas as compared to the rural areas, but as compared to other countries, our incidence is much, much high. And direct and indirect evidence of menopause increasing prevalence of metabolic syndrome is there now. Not only our studies, the other studies have also shown. So I won't be taking time in those. But as Dr. Sharda said, that these metabolic abnormalities not only lead on to prothrombotic state and obesity, everything, but there is non-alcoholic fatty liver disease, cardiovascular disease, more chances, 3 times, more 5 times chances of developing diabetes, cancers, especially breast, colorectal, liver, and obstructive sleep apnea. So that means these metabolic disorders are going to lead on to much more uh, morbidities than we are expecting. So that means we have to prevent them. Because once it is there, once the menopause is there, once menopause transition is there, if they are not already settled in, they will be settled in. Then we cannot do the prevention. If the prevention has to start, that has to start much earlier. So the patients, we can diagnose them in the menopause transition, those who are at risk factor. But what about those who have already had these abnormalities? So that is where the new thought process goes, that from where should we change that point? Where are the new factors? Because metabolic changes, we have seen correlation of metabolic syndrome to menopause, we have seen. So what are the new window of opportunity for diagnosis of cardiovascular disease assessment, early diagnosis, prevention, management, and what we do about it? So established traditional causes of CVD are hypertension, diabetes, dyslipidemia. I'm repeating again: obesity, unhealthy diet, sedentary lifestyle, smoking, stress, family history. Genetics are very, very important, which we are missing out. Genetics history should always be taken. The hypertension, diabetes, heart disease in the family and in your kids and kins, that should be taken not only in the parents but in grandparents, and your cousins, sisters and brothers also should be taken. So normal risk, global risk score is by the Fleming risk score, where we are counting the 6 main factors of the age, gender, blood pressure, diabetes, smoking, cholesterol measurement. These are the main factors. And if the score is categorized less than 6%, 10 years risk, then you can give these patients HRT. So I'm talking in relationship to HRT then. If we find these patients, then can we give them intermediate risk? They are at risk. You have to do the counseling and perhaps avoid high risk. You never give them. So that is the advantage of assessing these risk factors early when the patient comes to you. But that opportunity never comes to us, even just at the time of menopause. In menopause also, patients don't come to us for these diagnoses. They come to us mainly for the abnormal uterine bleeding. That is the commonest thing they will be coming up. Then maybe then the dryness of the vagina, itching somewhere. But they never come more than that problems like sleep problems or anything. So that is where we have to look into these problems. So postnatal care is important, but most of the deaths are occurring cardiovascular disease in the maternal deaths in the postpartum period only. And newborns are also dying. But we have a standard postpartum care by WHO is the first 24 hours immediate, early 2nd day to 7 days, late 8 days to 42 days. So conventionally, we stop postnatal care at 42 days. Ideally, normally, what is happening is that once the patient is discharged, that patient is gone for us. And discharge summaries are made in a very hurried way. We are taking the complete history. So that is where we have to change. Because we had an antenatal care, I've removed that slide of triangular. First, maximum visits used to be in the basement at the last trimester. Then we started having maximum visits in the first trimester. Then we added an attic there, the prenatal testing. And now we have to add another basement, which is very, very important, is the postnatal care. So that I'll go into why we are going to do that, because there are studies we have forced us to go into beyond that stage to look after the health of the women. One another very important hypothesis was given by Barker's hypothesis, 1980. But to convert that hypothesis into realities and evidence-based medicine has taken us so many years now. And for the last 2-3 years, already these guidelines are there, but we are still not looking into them. So this slide is not according to Barker's hypothesis in the women, but Barker's hypothesis effect being even in the intergenerational effect, because they have seen that abnormal vascularization of placenta and endothelial system in preeclampsia, in hypertensive disorders, in all the conditions of adverse pregnancy outcome where endothelial dysfunction was there. They have seen changes in the organs of fetus and future problems in mothers also. I'm not going into the details of the study, but you can take the references from me and go into the details of these studies. So, which are other studies which have shown that the CVD and sex-specific factors are important in cardiometabolic disorders? And Lancet has also come out that we are really ignoring the cardiac diseases in the women, which should we take an emergency call to these things. So ACOG committee redefining postpartum care guidelines came in 2018. And then they came out detailed care of the fourth trimester care. They extended the fourth trimester till 1 year of postpartum period also. I'll come to the how we have to do. So then came the call of the Lancet also that we are ignoring. Cardia study is a longitudinal study, and they have shown that it's not only other factor, but starting from race and genetics to the newborn period, to the adverse pregnancy outcome, to whatever the adolescent period the girls are having menarche and everything affects the later on health of women. So it's a continuous process. We cannot divide the health of women. We will be studying this one, this period, this period. It's a continuous process, and we have to take it like that only. So then came the white paper by International Menopause Society, Adverse Pregnancy Outcomes and Cardiometabolic Risk Factors in 2023. FIGO pregnancy passport came up that we should always have at the time of discharge of a woman, at the time of delivery, this FIGO passport ready for make her available and counsel her about the risk factors so that we can have a healthy aging later on. And our Indian study of found, which were done by me on relationship of menopause to metabolic syndrome, also highlighted the same thing. So this is the presidential task for redefining the postpartum visit. Committee of Obstetric Practice was set up in 2018, and then came the concept of fourth trimester of pregnancy. Now, why the fourth trimester of pregnancy? Because they seen the maximum deaths were occurring, cardiac and maternal deaths, in the postpartum period, first in the 6 days, then 21% between 7-41 days, but even 13% beyond 42 days. So that means where we see these adverse pregnancy outcome, in whichever women, we have to take them beyond those 42 days also, the really already defined period of the postpartum care. And now, so they started that you start the blood pressure checking on third day, then called her on after 3 weeks, and so that is where I'll take that later on. So what are the reproductive milestones and whatever cardiovascular disease risks are there in the women? This was a very beautiful umbrella review in BMJ 2020. And they say the increase in composite cardiovascular outcome, ischemic heart disease, stroke, heart failure, can be up to the extent of 3-fold to 1.5-fold, depending upon what was the problem. Recurrent preeclampsia is going to increase to 3-fold. 2-fold preeclampsia, stillbirth, preterm birth, gestational diabetes. COC is very important. And then came the, even when there is just the gestational diabetes, early menarche, PCOS, miscarriages, POI. So all these things are going to lead on to the increased risk of cardiovascular diseases late in the postpartum period and later also in the women. And what is reducing these risks is only factor they found was reduced longer breastfeeding. So immediately reduce longer breastfeeding is going to reduce these factors. So the incidence which will be there will be cardiomyopathic, thrombotic pulmonary, cerebrovascular accidents, hypertensive disorders of pregnancy, and other cardiovascular complications will be there. So identifying reproductive risk factors at an early stage in life of women might facilitate the initiation of strategies to modify potential risks policymakers should consider incorporating reproductive risk factor as part of assessment of cardiovascular risk in clinical guidelines. That is what we need. So this is the cardiac study, which is a longitudinal study, and they have seen everything in utero exposure, parental race, childhood exposures, early menarche, contraception, increased risk with PCOS, infertility, adverse pregnancy outcome, decreased lactation, menopausal symptoms, especially vasomotor symptoms, sleep disturbances, depression. They also lead on to early menopause, also will lead on to more risk of cardiovascular diseases. All these things are going to lead on to this thing. Along with that, inflammation and endothelial dysfunction, omic modification, and X chromosome inactivation, like Turner syndrome and other genomic variations are also going to increase the risk of cardiometabolic syndrome. So that's why we have to take a comprehensive risk when the risk assessment of the patient, when the patient comes to us during labor or before delivery, at the time of delivery, at the time of discharge, whenever our opportunity is there. And what is our opportunity now? Our institutional deliveries. Yes, that is our latest opportunity. Now the maternal mortality has been reduced, not because of anything happening magically. It is because government has taken the efforts to have more and more of institutional deliveries, and they have been taught properly to refer the patients in time. So that is why the women are getting a better care. Now we have those patients, we have an infrastructure, we have everything. The only thing is we need is now proper OPD cards. That's all. That is what the FIGO passport is. That is what I have also designed these cards, where you can just tick mark all these risk factors. So traditionally, if the history of high blood pressure is there 3 to 10 days, then 1 to 3 weeks, every 6 weeks, but go it beyond 6 weeks to 1 year, and even beyond 1 year, where the patient has persistence of the gestational diabetes, weight retention, depression, lactation is there. And at the time of discharge, you decide where the patient goes to, whether she goes to a gynecologist, she goes to a cardiologist, she goes to a dietitian for weight reduction, for psychological assessment, counseling, or perhaps everything combined together. But that patient is yours. That patient is obstetrician, gynecologist, and we should always call them back. But at the same time, counsel them about all these factors, and this I will be coming again in the FIGO passport. So if there are hypertensive disorders of pregnancy, they are going to lead. We have to tell to the patient, not 100%, but 4 times more of developing chronic hypertension, 3 times more likely to develop metabolic syndrome, 2 times more likely to develop cardiovascular disease, 2 times more likely to develop chronic kidney disease, and 2 times higher risk of diabetes 2 mellitus. And same way, if gestational diabetes mellitus is there, 8 to 10-fold risk of developing type 2 diabetes mellitus and 2-fold higher risk of developing cardiovascular disease. So you cannot say that the gestational diabetes will be cured after delivery. No, we have to follow them up properly. So that is very important. So pregnancy is now recognized as a physiological stress that can unmask pre-existing or subclinical diseases that may manifest later in life and can have intergenerational effect also. Women who experience complications during pregnancy, such as hypertensive disorders, whatever I mean, so they are more at risk of cardiometabolic disease. Now we come to the FIGO pregnancy passport. Now FIGO is like a god for us. So whatever the FIGO guidelines come, we take it very religiously. But why we have not understood these guidelines? Because this has been there for the last 2 years. Since 2023, I have been talking on this FIGO pregnancy passport. The pregnancy is often considered a physiological stress that I have already highlighted. So FIGO Committee on Impact of Pregnancy on Long-Term Health believes that the innovative pregnancy passport would be the most convenient, pragmatic, and effective tool for postpartum care to achieve this goal, and should be used wisely and globally. So the same way, Lancet also came up that we are under-studied, cardiovascular disease is under-studied, under-recognized, under-diagnosed, under-treatment. and American Heart Association also had come up with the same guidelines that we have to ignite the global awareness. So this is a white paper which was there on the World Menopause Day in October 2023, and they said the reproductive milestones across the lifespan and cardiovascular disease risk in movement increases. All these factors increase the risk in the menopause of all the metabolic disparities which are there. So then where the prevention starts, early menarche, irregular period, adverse pregnancy outcome, menopause hormone therapy, if given late, breast cancer survivors don't die of breast cancer, but they die of because of the endocrine treatment given to them, or chemotherapy is given to them, or radiation given to them. And contraception is not given in the proper way. So that is why the women at risk should be advised contraception in a proper way, perhaps only progesterone, only pills, or the barrier method, whatever, depending upon the risk of the women. So this is the summary of all these things. You can take a picture also. So starting from menstrual cyclicity, irregularity, early menarche, polycystic ovarian syndrome, important functional hypothalamic amenorrhea, hormone-based contraception, infertility treatment, especially ovulation treatment, ovulatory adverse pregnancy outcomes, preeclampsia, all these factors we have highlighted, breast cancer, radiation, small gestation weight, all these factors should be understood. Now, very easy to remember. There is nothing difficult in it at all. So we have well-established risk factors which we counted: hypertension, overweight, everything, sex-specific risk factor, early menarche, early menopause, premature menopause, and menopausal symptom. Under-recognized risk factors are something which I am going to talk. Then menopausal symptoms and menopause-related metabolic changes we have already talked. So under-related
Ma'am, your volume is very low.
अरे मैं बोल तो बहुत ऊंचा रही हूँ, मेरे ख्याल से स्पीकर्स मेरे नहीं काम कर रहे हैं.
मैम
अब ठीक
वॉल्यूम
है,
बहुत कम है.
अब ठीक है, अब तो मेरी खत्म होने ये नॉइस
अब
ओके.
ठीक है, अब ठीक है मैम.
So I keep my face.
Ma'am, you should be closer to your mic.
Mic is laptop is only, and laptop is very very dear to my face. Anyway, the underrated risk factor now it's okay.
Yes, ma'am. Now we can hear you.
Psychosocial depression and anxiety, abuse and intimate partner violence, that is very important, and socio-economic and cultural status, which we are always forgetting, race and poverty, poor health, literacy, environmental risk factors, air pollution, that is very, very important, which we are ignoring completely. Just look at our fans, ceiling fans, we clean them, and after 2 weeks, there is still that black coating again on our ceiling fan. What is happening to our body? What is happening to our lungs? What is happening to our system? We are not even looking into that. Now am I audible?
Yes, yes.
Am I audible now? Yeah.
Yes, ma'am.
Postnatal care in India is very poor. That has been seen in many studies, and the coverage of essential even postnatal care is inadequate, especially for the mother from economically disadvantaged households. So now, what is our opportunity now? When? So I come to this thing. When starting from school health programs, recognize those girls of PCOS or overweight, then recognize these women with adverse pregnancy outcomes as I highlighted. I'll again repeat them here. All the pregnancy, preeclampsia, hypertensive disorders, gestational diabetes, early abortions, preterm labor, stillbirth, all these are adverse pregnancy outcomes which we should be recognizing in the postnatal period and during the pregnancy or antenatal period, and taking them an extended care, and later on we can take them into the wellness clinics after 2 or 3 years, even when we feel that the patient needs a care. So then comes the next opportunity, comes the menopause transition. If the patients come to you and you are running a menopause clinic, perhaps they will come to you as a 40+ clinic, and at that time you have another opportunity, though that is not an early opportunity, but any missed opportunity is a bad missed opportunity. So no opportunity should be missed in these cases. And how we can help these cases? Very important, very simple interventions like breastfeeding, lifestyle, exercising. That is very, very important, because now innumerable studies have come up that the walking or yoga is not sufficient. And after 30 plus, you have to add some 2 or 3 days of resistance or weight training also. Dietary modifications are required, that the government of India should look into what type of food is our public is getting. At least refined carbohydrate should be banned completely. Vaccination, cancer screening, we can do in these women if we call them again and again. Patient education, we can do. Women empowerment through knowledge. Wherever needed, we can start with the medication for the blood pressure or lipid lowering drugs or kidney problems or whatever, where we need these patients to put on treatment. But breastfeeding is something which we have to tell them, please go on breastfeeding even for 2 years. That it's that even going to help you out, even prevention of cancers also. This is my studies where they have statistical significance with the weight-based blood pressure, hemoglobin A1C, HDL, LDL, triglyceride, they were related to this thing. And moreover, what we find important was that sleep disturbances, they were also related to increased incidence of metabolic syndrome. So if we have these women, before putting them on menopause hormone therapy, please assess them completely for cardiometabolic risk factors. Even they say do CT and GO or do MRI or take the help of cardiologists for doing interventional cardiology if needed before putting them on HRT. Because if the plaque is sitting there, then plaque disruption will be there and women will have heart attack. Otherwise, early menopause transition, menopause hormone therapy is safe to give. Yes, physical activity has statistical significance at all stages of life. PCOS we have talked about. These are my families where obesity is running. So our challenges are that we have to start with the extended post-trimester care and then perhaps take them to the wellness clinic. And for that, we need leaders, like Dr. Sharda Jain. Dr. Sharda Jain is one of those leaders who can always raise their voice that yes, these opportunities, extended opportunities should be given to our rural women, because we can give from our clinics, no problem. We'll have a better quality of practice here. But those women should always be called back, and at the time of discharge, only discharge, whether they go to the physician, cardiopulmonary, gynecologist, weight therapies for depression or self-help tools are given to the patient. This is the FIGO pregnancy passport, which is nothing but a 4-page folded part. First part, second page, third, and fourth page. That is all. You call them, take them their history, which I am showing you what history they are going to take, and call them back at 6 months, 3 months, 6 weeks, 3 months, 6 months, 1 year, and beyond 1 year when needed in gestational diabetes or hypertension. And risk indicators for patient information should be there. They should always be counseled what they can do among themselves. So FIGO passport has not included these factors of breast cancer, PCOS, hypothalamic amenorrhea, COC, ART patients. That we should include. Those who are copying from FIGO passport, or they can have these OPD cards from me only, and then they can add these patients in their risk assessment tool. This is what the risk assessment tool is. FIGO page 1. Name, baby's information, and complete ethnicity, and what are the previous histories of hypertension, everything. Second page, what are you had your during your risk previous pregnancy or this pregnancy, what they had. Preeclampsia, gestational hypertension, gestational diabetes, abruption, preterm labor, fetal growth restriction, or stillbirth. So that is, you have to fill up just yes, no, that's all. And then you have to tell patient, but I told you already, if they are hypertensive, there are more chances of their developing high blood pressure, heart disease, stroke, kidney disease, diabetes, and the venous thromboembolism. So they have to be told what they have to be doing to prevent them. So what they should be preventing is given in the last page again at the end. So they have to given their date.
Maninder, another 2 minutes only. Maninder, another 2 minutes.
Last time, madam. Last time, yes. This is the fourth page. So this is at the time of discharge. You have to tell them and call them. Give them dates. At these dates, they have to come back and they will come back. Tell them how they have to control their blood pressure, weight, nutrition, and lifestyle modification. This is how they will be told about everything in detail. So this is the healthy aging, and as everything we have said, we transition into Udan Wellness Clinic. Let's have a free midlife and a healthy midlife. So if we have to start with the future of all the things we have required. But the main thing is that promote and propagate. And key principles are to identify earlier government of India policy changes, authority card changes, all them recognize them early, and we have the opportunity of institutional delivery, take the help of technology, skill, joint. I think I think we will be one of the biggest thought players. Thank you. I'll stop sharing.